My name is Casey Ulrich. I am the manager for HIT consultation for Community Health Partners for Sustainability. And on behalf of Community Health Partners and the National Center for Health and Public Housing, I want to thank you again for joining us and taking part in this great event. We're very happy to have you here. I think this is a very important issue we're going to talk about this morning for health centers and health advocates. Again, we were prompted by the questioner before, but as part of our technical assistance, I've had the pleasure of going out and conducting free health IT assessments at health centers across the country. And as Dr. Hayashi mentioned in his presentation yesterday morning, health centers have really made some terrific progress implementing health IT systems, attesting for meaningful use, and even receiving patient-centered home recognition. However, I worry that these impressive technological edifices and successes are maybe built on some shaky foundations. And I say that after, again, as part of these assessments, looking at the governance structures of health IT, how folks are implementing privacy and security policies around their systems, how they're optimizing their systems for meaningful use or PCMH standards. After speaking with COOs, application managers, providers, and frontline staff, your MAs and the front desk, they've shared their concerns about health IT with me. And these include the high costs of maintaining HIT systems like EHRs, the high costs of upgrading for meaningful use, and the hassles and the costs associated with implementing interoperability platforms so that you can share information with critical community partners like hospitals, referral specialists, and public health registries. In addition, there's the issues of staff turnover resulting in needs for training and retraining, and the constant threat of provider and staff fatigue that comes with the introduction of new HIT systems like population health management tools or patient portals. So as a result of these health assessments, we've been able to connect health centers with training resources and education to kind of strengthen their foundations. And despite all the difficulties, we believe that the promise of smart, efficient health IT is worth the effort. And this morning's presenters will speak to how their organizations are supporting and tracking the optimization and the adoption of health IT, the challenge that health centers are facing across the country, integrating technology into the clinical setting, and the benefits that they've realized for those who are willing to put in the work. So without further ado, I want to just make a quick introduction of our speakers. The first speaker will be Fadesola Adetosoye. I hope I got that right. She is the Public Affairs Manager for the Office of National Coordinator for Health IT at the U.S. Department of Health and Human Services. As Public Affairs Manager, she leads communication and partnership efforts between the organization and stakeholders with interests in payment reform and new care delivery models. She serves as a senior advisor to ONC leadership on various health IT-related and policy issues. And prior to this, Fadesola led program management activities on the Regional Extension Center program at ONC. The Regional Extension Center program works with nearly half of primary care providers across the U.S. to adopt, implement, and meaningfully use health IT in a way that improves clinical outcomes, improves quality, and costs for all. Our next speaker will be Shane Hickey. He is the Director of Health Information Technology Support for the National Association of Community Health Centers, NAC. In this role, he spearheads the National Health Information Technology Strategy and Support Program for the Trade Association, representing over 9,000 federally qualified health center sites across all 50 states and U.S. territories. He possesses an extensive education and acumen in healthcare information technology management, business and project management, and has worked in a variety of healthcare settings, such as multi-state continuing care retirement community, a large integrated healthcare delivery system, and at health centers. Prior to joining NAC, he worked for MedStar Health, where he managed and implemented large-scale innovative HIT projects for a $4.2 billion system that included the implementation, training, and support of an ambulatory electronic health record system, interfaces, a data center migration, e-prescribing, patient portal, secure messaging, and population health management tools. And then finally, our last speaker will be Paula Tomko. She served as the Chief Operating Officer for Central Virginia Health Services since 2010. Prior to that, she was Director of Administrative Operations and Human Resources Director. And before coming to CVHS, Paula served as a Human Resource Specialist with a startup technology company and Human Resource Administrator for Liberty Fabrics. Paula is going to speak a little bit towards the challenges that many of you are familiar with as health center grantees, adopting and optimizing health IT. So I will turn it over to our first speaker.
Good morning. Thank you for inviting me to speak today, Casey and Rachel. And it's a pleasure to be speaking to a group of health center leaders, thought leaders, and those that have an interest in population health and the use of health information technology to do that. And so before I get started, I just want to give a bit of my background. I am pretty much a patient care advocate and come from a background in health policy within the academic and private hospital healthcare system. In 2008, my mom was actually diagnosed with end-stage renal disease, and that experience really was a wake-up call to the number of inefficiencies and confusion that plague our healthcare system. And so in 2009, I had the opportunity to join the National Coordinator for Health IT, as one of the 3 staff members to start up the Regional Extension Center program. And I'm not sure how many of you are familiar with the REC program, but it was legislatively mandated through the Health Information Technology and Economic Clinical Health Act, referred to HITECH, under President Obama's 2009 ARA enactment. And today, I currently serve as, the public affairs manager there, as well as in the community, co-chair of the disparities interest group with Academy Health, really looking at health services research and policy that's related to advancing health equity across the U.S. And so my experiences to date highlight that health IT has a number of advantages to improving clinical health outcomes for all. And so today I hope to speak a little bit about what ONC is doing to advance the national healthcare agenda, specifically through use of digital technologies such as electronic health records, patient portals, and mobile health apps. So this April marked the 10-year anniversary of ONC's service to America. And we at ONC, the office was actually established in 2004 under President George Bush as the entity charged with providing policy recommendations and leading nationwide efforts to implement and use advanced health information technology to improve the healthcare ecosystem. And so, as I mentioned earlier, we, in 2009, were legislatively mandated through HITECH to advance the agenda of health IT to improve quality care and reduce costs of healthcare across the U.S. And specifically as a way of really thinking about how IT can advance the triple aim objectives under the Affordable Care Act. And so, when you think about it, U.S. Health information takes up 1/5 of the economy. That's 20% of the gross domestic product. And so how we effectively manage and coordinate the information of healthcare for physicians and patients is critical to achieving the goals under the Affordable Care Act, HITECH, and future care delivery programs coming down the pipeline. And so at ONC, we have made great strides to the adoption of EHRs and the advancement of health IT. And so our next challenge really as a nation, and specifically at ONC, is to figure out a way to liberate and mobilize that data so that patients and providers have it at the right time when they need it. And I'm sure those of you that work in the community health centers know all too well the disparities and some of the challenges that arise when we have urgent care needs, and the information on our population, whether it's homeless, underserved, you don't have it at the point of care. And so we remain focused on addressing these issues, and specifically health information exchange, privacy and security, standards, equity in the system, certification, and ensuring that there is a federal and nationwide coordination in our strategic approach to using health IT. And to do that, ONC has executed a number of programs that foster care transformation collaboratives at the local level, and the dissemination of best practices related to the use of health IT to improve population health. And so I'm going to list a few of our programs, and I'm sure those of you at health centers may or may have not worked closely with them. And so one program, for example, is the Beacon program, which demonstrated best practices to use of health IT at the local level to promote care transformation and care coordination efforts to, again, improve population health. Our Regional Extension Center program, which is probably one of the programs that is our claim to fame at ONC, currently works with 130,000 primary care, or providers rather, and of the 130,000 providers that they work with, more than 40% of them represent the primary care physician workforce across the United States. And so the goal of this program is to provide technical assistance to these providers in the field to adopt and advance the meaningful use of health IT within their practices. These centers often serve as learning systems to continuously educate and serve as a resource to patients and physicians interested in the clinical and behavioral advancements in healthcare using health IT. Furthermore, this program is working with 83% of FQHCs and FQHC lookalikes across the country to again adopt, implement, and meaningfully use health IT, and it's actually served as the foundation for a number of the programs that FQHCs are participating in, such as the medical home model, state innovation grants, and some of the other innovation grants that are coming out of CMS. And this program specifically also is a good, or demonstrates ONC's commitment to ensuring that communities serviced by the safety net centers or providers are aware and receive the benefits that health IT can provide, including patient education resources, clinical decision support, for the clinicians who service these communities, and the ability to help patients get their information when they need it and how they need it. And so when we think about some of the challenges we've heard earlier in terms of consultancy around those with health IT expertise, some of the financial barriers to just adopting information technology in a workforce to sustain that, the RACs have been a vital lifeline, if you will, to ensuring that health centers can take care or participate in these programs without furthering a digital divide in healthcare. And then we have our state health information exchange, which builds infrastructure across the country to facilitate exchange and interoperability of health information, which we continue to build upon today in an effort to improve care coordination, transitions of care, and increase consumer engagement in their care and their health. And then our consumer engagement efforts, such as Blue Button, are providing opportunities for meaningful consumer engagement in their care and health. Through the Blue Button Initiative and Stage 2 of the EHR Incentive Program, which many of you refer to as meaningful use, more patients have access to their hospital or provider health data. In addition to this, things like the Blue Button Initiative and some of our consumer engagement efforts are developing an open source database of patient reporting assessment tools that providers can incorporate into their care delivery. And again, so these programs are very crucial to our nation's health improvement efforts and demonstrate HHS's commitment to implementing an effective health information technology infrastructure that elevates patient-centered care, improves health outcomes, and supports providers that care for the patients. And so, to do this, we all know that the systems need to be interoperable. We need to be able to communicate with one another across various care settings. And so health information exchange and interoperability remain top priority for ONC. Over the next few years, we know that the care delivery system will realize a broader degree of interoperability and exchange, which will allow healthcare providers to trend and aggregate information within and across groups of their patients based on information from multiple data sources to monitor health disparities and quality improvement opportunities within their individual office. And this is very important. We know that the Affordable Care Act has now provided millions of Americans who were formerly underinsured or uninsured with access to health care. And so how these new entrants into the healthcare system manage and access their health information is extremely important to experiencing the clinical outcomes we desire to see. And we know in research and case studies that health IT is an integral part of ensuring that that happens the way we want it to happen. And so there's a lot of focus at ONC here on the Meaningful Use program, and while Meaningful Use creates the foundation for interoperability, it is now time for us to move beyond MU to drive interoperability across the care continuum by marrying standards into federal policies that will facilitate many different types of exchange over the next several years. And to meet the demand of delivery system reform, ONC is focusing on 5 elements, which include adoption and optimization of EHRs and HIE services, standards to support implementation and certification, financial and clinical incentives, privacy and security, and rules of engagement for governance, which I'm sure many of you are interested in. And so last week, we actually released a concept paper on interoperability, which defines and describes our future steps. I encourage you all to look at that and and that's available on www.healthit.gov. As health centers and safety net providers, I think it's important that we hear your feedback and really think about the challenges and barriers within this specific setting to servicing our safety net population. And so in terms of the future of ONC, we remain focused on consumer demand and making sure we educate patients that they have the right to access their health information privately and securely, whether it's in paper or electronic format, and to provide providers the ability to get their patients health information when they need it so they can give patients the right care at the right time. And so we are doing this through, again, a 5-year strategic plan. And our goal at ONC is to be very, very transparent. And so the strategic plan is a roadmap to how we plan to do this over the next 5 years. And then later this year, we're looking forward to working with our Health IT Policy Committee and the broader community, including people like you, on a national consensus agenda on Health IT. And so last week, we actually put out a call for new members to our federal advisory committees. I hope some of you in the audience applied. If not, feel free to buzz me afterwards and we can figure out if there's something we can do. And so I want to thank you all for your time, and I'm going to turn it back over to Casey. That's my buzz. Thanks.
Well, good morning, everyone. I'm Shane Hickey, the Director of Health Information Technology Support for the National Association of Community Health Centers, also known as NAC. It's a pleasure and honor to be here and joined by such a distinguished panel and yourselves. So thank you for having me today. I think what's unique about this panel is the different perspectives that we bring. So Fadesola, she represents the Office of National Coordinator and transcends health centers. So, they're looking at the whole health IT landscape, from a national standpoint, not only for health centers, but for all, ambulatory care providers and hospitals. I bring the perspective of a national viewpoint for health centers. And then we have Paula that is from a health center, and we'll talk about some of the lessons learned and challenges that they're facing on the ground. So we're hopeful that today's discussion will be a rich one for you, and we do appreciate the segue from Manette, your community health center. If that was a great introduction. So for folks that don't know, just put a quick plug in for my organization that I work for. We are a trade association founded in 1971 and provide a unified voice and common source for research, information, advocacy for community health centers. We work with a variety of state-based and primary care associations across the country, and to do all sorts of things. One is to provide research-based advocacy. Two is educate the public about our mission and the value of health centers. Three is to train and provide technical assistance, which is a big part of what we do, and actually the department which I'm based out of. And fourth is to develop alliances with private partners and key stakeholders. So how I spend most of my days in the office is really on the phone with you guys, with health centers, primary care associations, and health center control networks. We have a very strong partnership with all of those organizations, and really providing technical assistance and consultation on a daily basis. So when you look at the magnitude and the scope of the health center program, you know, health centers are not your mom and pop shops anymore. You know, when collectively, when we're all combined, you know, we serve 22.3 million patients. That equates to 88.3 million annual patient visits at over 9,000 sites of care, and staffed by 153,000 employees. So I think it is the largest network of providers in the country. So putting that into perspective with health IT and community health centers, you know, I think Fadesola was the one that mentioned, you know, health IT is really to support the triple aim, or it's intended to, you know, improving quality, increasing safety, efficiency, reducing the cost of care, and ultimately improving the health outcomes of patients and populations that we serve. And one advantage or one utility of health information technology and what it can do is really reduce the disparities that our patients are really are subject to if used in the right ways. So, you know, they can improve, HIT can do lots of different things, but, you know, improves areas such as care coordination, which came up earlier, patient engagement. It offers opportunities to standardize our workflow, our processes, and our operations, and really provide clinical decision support based on evidence-based guidelines. So it's taking what the best practices out there and really integrated that as part of your workflows. So, you know, when we look back just a little ways, not too far, but in 2006, safety net providers were adopting EHRs at much lower rates than other ambulatory care providers. And in fact, 26% of health centers back then had any EHR capacity. You know, since 2007, HRSA has made substantial investments in health information technology, $121 million, in fact, to support HIT-related projects, not only to health centers, but also health center-controlled networks. And those are groups of health centers that have kind of come together and formed an organization to share resources across multiple disparate organizations. And so the latest figures that I've seen that's provided by the Bureau is that over 60% of all health centers are connected to a health center-controlled network today, which is remarkable, you know, compared to where the health center control network started from. You know, health centers, you know, so we know back in 2006, you know, we were at a 26% adoption rate. When you look at the UDS data today, health centers have adopted EHRs, or 90% of health centers have adopted EHRs, which is huge. I think more so than any other care provider that is out there. And so that presents a lot of opportunities and also provides the associated challenges with that. But even when you look at the differences between years like in 2011 and 2012, you know, when you look at the data, I think we made a 10% jump in those folks that had adopted electronic health records, at least at some of their sites, and then a 14% jump of those that have adopted electronic health records across all of their sites. And so that's just in 1 year. And so we're really eager to see what the next year's data actually looks like. Also, we don't have, as we know, as health centers, we don't have one electronic health record. Apparently, we have about 43 different EHR systems that health centers are using, but 10 of those EHR systems account for 90% of the systems that health centers are using. And so, one of the resources that we provide as NAC is access to electronic health record user groups. So we focus on the top 6 most dominant vendors and make that available to all health centers and primary care associations and health center control networks to participate. And I'll talk more about that as we go on. Some other data that I just wanted to share with you. This actually came from the Bureau, and it was reported by health center controlled networks in their progress reports about, we said that 60% of health centers are connected to a network. Well, how are those health centers faring when you look at patient-centered medical home attainment, when you look at meaningful use? And, almost 90% of eligible professionals, at least that are part of these networks, were on ONC certified EHRs. 76% had attested to stage 1 meaningful use. And 68% had received meaningful use payments, and almost 42% had new or increased PCMH recognition status. And even 92% had met one Healthy People 2020 goal. Definitely making strides as far as that. Obviously, those figures are not representative of the total population because it's only what the networks had reported. But at least those results are encouraging. So, I think there's as our friend in the back had alluded to, there's a number of challenges when trying to adopt health information technology and barriers that we're all facing. I mean, some of the most common that I hear from where I sit is really the additional investments in expensive interfaces and additional products such as patient portals that were not part of the certified EHR, but what you're having to buy after the fact. So health information exchange interoperability is big focus of ONC and the new national coordinator, as Fadesola had alluded to. And a lot of times what I hear from health centers is that they're having to purchase each interface that they have to, in order to connect with the health information exchange, that's another outlay of cash that wasn't originally budgeted for. And we all know cash is so scarce within the organization. And so that's a very common barrier that I hear across the board. Another is lost provider productivity. So once you go onto EHRs, typically there's a dip in provider productivity as the providers are adapting to the new changes and getting comfortable with the system. Ongoing training, maintenance, and IT support costs. As we all know, HIT is not a one-time investment. It's something that's you have to budget for, and there's ongoing support maintenance costs, and including staff to have some expertise in-house. It's important to have that. So not having those resources or for a single dedicated person or team responsible for the optimization of the EHR can be challenging. Other things are lack of time to really set aside for training and optimization support, poor vendor training on EMR features, including alerts, templates, and reporting tools, the overuse of customization, just to get it to work the way we want it to work, and lack of interoperability. So as we look ahead to stage 2 meaningful use, for the first stage of meaningful use was really focused on capturing the data, capturing it in electronic format. The second stage is really looking at, well, how are we using the data? How are we exchanging it to really support care coordination, focus on health information exchange, patient engagement with patient portals, and optimization. So I don't know if you guys have seen it, but it just recently came out, a notice of proposed rulemaking from CMS and ONC, which is allowing some additional flexibility for stage 2. So it was that you would have to upgrade your EHR to the 2014 certified version this year, and what they're proposing is that you could still attest to stage 2 using your old technology if in the event you were having difficulties upgrading, that you could take advantage of that. And then also, as we look ahead, ICD-10, we are gearing up for that. So we have a new date established for that, October 1st, 2015, that we're gearing up for. And we are actually partnering with the California PCA to do some trainings around that. And so we're planning to do at least something once per month starting in the July-August timeframe. So keep an eye out for that. So, we have different initiatives at NAC that we're working on. And those are, is really EHR optimization. We're working with a network of health centers as well as health center controlled networks, and really building some clinical decision support within the most dominant EHR vendors, and to really provide that decision support at the point of care and not retrospectively. That's one thing. We're working on a national patient risk assessment tool that really focuses on the social determinants of health, because we know those are important factors for the patient populations that we serve. And I mentioned the user groups. Those are free, and you're welcome to take advantage of that. So I just mindful of the time, but I'm going to go ahead and turn it over to our next panelist. So thank you.
I guess I could have just let Shane keep talking and say what he said. My best advice to you after listening to them is just make sure you have his name and number and contact information, put it on speed dial, and get to work. Now, is there anybody out here who has not implemented an HEHR yet? Oh, we all envy you. No, after having been through this. So our primary care association was asked to provide someone who they felt had HIT under their hat. After Casey said that, I thought this was a little bit probably like that game, Whisper Down the Alley or Telephone, depending where you grew up, because there's no way I think that I have HIT under our hat. I come from a community health center that serves, we have 14 different locations, and it's a mixture of urban and rural sites. And I appreciate being here today to talk with you guys who are more of a targeted population, because it is a very hard situation. As Shane said, we are healthcare providers that have gone into this business, and so much of our business is now being driven by our IT. And we don't have that experience, we don't have the budget for it, so how do we make it happen? And so they asked me to talk about a few things with pitfalls and things like that. We have just recently implemented, and by recently I mean within 2013. We talked about it for years. My boss cloned a phrase at our site of that we were gonna let everybody else lay down on the barbed wire, and we were gonna go over them and learn from their mistakes. That was a great theory, but in my concept, everybody went through the barbed wire fence here, and we went over here, so it really didn't matter. And so we did not learn as much from our peers as we could have or should have. We chose, in Virginia, the Primary Care Association and the network. Most of the sites all use the same system. There are a few of us rebels that said, we're gonna do this our way, and we were one of those. And we're paying the price for it now. And so some of the things that I just kind of wanted to talk to, and then I think the best help is for you guys to ask us questions about what you're struggling with, were one of the things they asked me to talk about were pitfalls. And so like I said, we have 14 sites. It took us 6 months to implement. We did gradual rollouts. My biggest problem was I did not think ahead or understand the need for having 2 training teams. I needed one team that was out there with every new startup, if you're multiple locations, and I needed another team to go back behind and reinforce. We started out with super users, what they called super users, and we had those at the first sites we implemented. Well, then we took them away to move on to operating because our EHR said, oh, well, the super users have to come with us to learn how to train. So actually, our 2 sites that came up first were 2 of the slowest sites to then adapt, adjust, and recover, because we all learned along the way, and the rest of us got better, and the best of the implementations got better, but those folks still struggled because we still had to work out of a lot of issues through that. So the question is, are any of you considering going into your second HEHR, or have you moved? Did you change vendors? No, okay. Well, so we have actually not talked about changing, because again, it's just been a year, but it was understanding from folks. We were so disgruntled after a few months and implementations, we took a break. And we actually said, we moved one of the sites to the end and said, we've got to regroup because our training isn't working and we need to catch these first sites up. So had we not made that change, that would have been a big problem. So if you're doing multi-sites, I would definitely encourage you to put a break in there. So one, your staff needs a break of training because it was rigorous for those of you who remember doing it. And it's hard on everyone. But look for the stars. We did definitely find some star employees in this that adapted and looked well, and they have made great. We've been able to access those employees in such a different way and engage them, and they've been a really good help to us. My other piece of advice, don't pay the bill until you have what you want. Because as soon as you pay the majority of the bill, they start to disengage with you as the vendor. And we were, and I won't name our HEHR to protect the innocent, but when we agreed with them to go with them, they had an agreement for lab services. By the time we actually implemented, because again, we're rural, we had to get IT bandwidth updated, they had to lay like 5 miles of fiber optics to get to our one site. So it took a long time for us to get ready to go. But in that time, the lab vendor dropped the interface, so we had to build a new interface. We went live last year. I'm just turning the bidirectional lab interface up this year, and now they're pushing me and saying, well, we have other customers. I said, excuse me, we're waiting 14, 15 months for something, and now you're gonna rush me in a week? You can wait. But I also owe them money, and so that's the only reason we're getting response on some of our issues. And what Shane said about interfaces, that is so key. Every time somebody wants information, we can't give it to them, or we have to build another interface, and our CFO's like, more money, and I'm like, yes, Charles, more money. It never comes off the agenda, and it never comes out of the budget, so you've got to be prepared for that. And I think, and another pitfall that I think other people make that I don't think we did was sort of something Oscar alluded to in the earlier presentation, is that you've got to involve all the staff. For the most part, it really only affected the clinical side of things. It affected our providers, it affected all our nursing staff, referral clerks, those folks. But the front office staff thought they could sit over here in a vacuum, and we didn't leave them out simply because we needed them to support the other staff. We needed them to understand the other staff was going through a really hard time to do this. I have 43 providers, mostly all full-time providers, and some have been with us 28 years, some have been with us 1 year. And so some of those folks who had been out 28 years had never had to work on an electronic health record, really did not buy into it. And so we really needed the front office staff to understand how it was going to impact them and to be supportive. And we use the option that lots of times everything we do boils down to the front office. Now you have to collect this information, now you have to change this slide, now you have to do that. This time, you guys really don't have to do anything. Just keep what you're doing, but support your teammates over here because life has radically changed for them. One of our pitfalls was our clinical summary was not what we wanted. First of all, the providers wanted the clinical summary to be discharge summary. Well, it wasn't. And so if anybody's looking at a system again, my advice would be make sure you understand how the clinical summary really reads from the note. I think the hardest thing, and again, Shane alluded to it, is that we're not IT people. We didn't know what to expect. This is so much of a change of what we're doing. And so people demoed the product, and everything looked good. It worked quick. I don't know how many of you got your EHRs up, and then they don't work as fast as they did in the demo, and your doctors are standing there going, why does this keep doing this? And you're like, talk to the patient. That was one of your complaints. You said you were going to lose FaceTime. Here's your FaceTime with the patient. Well, that's just spinning around and waiting. So that was a really hard thing, and we're still struggling with that. But one of the things, and the other thing about the clinical summary and meaningful use is that, as I said to the providers, what you think is meaningful is not what the government thinks is meaningful, and so let's just get that out on the table now, because it's not the same thing. And so trying to get folks to understand, we want to make it what we can, because one, we need the money to help keep paying for this, and we need to collect it. But let's just make some changes and let's give us good feedback. So one of my suggestions is to make sure when you listen to your providers, have a filter in your mind to filter out the frustration from the honest to goodness good suggestions. Because sometimes you get lost in that because you're battle worn. If you're in charge of implementing it, you don't want to go to work. And as I told the providers and the staff, I said, you don't want to come to work and do this? I don't want to come to work and do this, because every day I open my email with trepidation, going, what's going to happen now? The best thing that I could do was get off the implementation team after a while, because I just took everything personal. I was a huge, I just felt like a huge failure. But my CEO was kind enough to say, you got in on time, we achieved 90% meaningful use, finishing up our implementation in August, and we were able to file for our 90-day meaningful use and get all our stage 1 money. So we did a good job, but like I said, there were a lot of battle-worn people left behind me in the wake of it, and some of that was patients, because it did cut down on our access. We weren't able to get patients in the way we were supposed to. And the way we drill that down is access, get, productivity, get those patients in, they need to be seen. And so there were really hard periods where we had so many patient complaints. So on top of our staff yelling at us, now we're getting all these patient complaints about why they can't get in the door to see us, they can't get appointments. And so you have to think of the whole picture of everything, where it's going to do that. And so how did we get buy-in was another question they thought I should address, because we did actually get buy-in, and I have to applaud our CEO for actually taking the time to meet with every provider one-on-one. We sat down with them, we said, what are you worried about with HEHR? What do you think is gonna happen? Are you ready? Part of the good thing was that he found out everybody was ready. Even some of the providers that we thought couldn't even type an email were at least saying, I know it's coming. I can't avoid it any longer. We lost some providers along the way, some for very legitimate reasons, and some just said, you know what, I think I'm gonna get out now and go to someplace else that's already fully employed with their HEHR, which I understand, because the other thing we didn't know is how much stuff you have to set up ahead of time to customize it. Most of us just thought, well, ICD-9 standard, DX codes are standard, why can't you have all that loaded? Why did we have to put so much in? So one of my questions to the next vendor that we look at is going to be, how do you collect your data for meaningful use? Because it was really nice that they showed us this report that said, here's your meaningful use report, here's all your percentages and stuff, and you can see that you made it. It's really easy to look at. But they didn't tell you, one, it takes forever to do it. You have to do it by provider. You can't just look at everybody at one time. But they didn't tell you how it collected that data, and so some of the steps that our providers have to go through to make sure that we can get the data to put the report out is hard. So I would encourage everyone to really take advantage of Shane again. We have a very strong primary care association in Virginia. We're very fortunate, and they funnel a lot of that down for us. But if you do not have that network, I would definitely get Shane's number and stay in touch. And one of the last questions, because I know I'm running out of time and I could talk all day on this, is are your providers going to buy into it, or how are they going to use it? And it's really important, I think, for those of you who are administrators, and I put myself in that. I'm not a clinician. I have a healthcare management background, but I value what our providers do. I am passionate about what health centers do. And so it is really important for you guys as administrators to be able to show them how the results are captured, what they can do with the data. We've implemented care coordinators to try and get those patients back into care that we lost, either through loss of productivity or we can't track. And so it's showing them that the patient that they thought just hadn't been in for 6 months really hadn't been in for a year, but like most of us were like, oh, it's June already? Where'd that year go? The same thing happens with patients. And so being able to show them how they can use the data is going to be very important to getting them to buy in, as well as also hoping to be a voice to make change to the programs that are out there. Thank you.
Hello. All right, so we've got some time for a few questions. I want to thank all of our panelists. That was really great. And we've got some experts, some great resources up here. So what are your questions? What are your feelings about this? So we have a couple microphones around. Does anybody have a question for any of our panelists? Oh, I see a question over there. And hold on just one second. Yeah, you can go over to that. Devin's got you. All right.
Thank you. I don't know if my question's for Shane. It's about health center controlled networks. I'm not sure I understand what the real goal of health center controlled networks are beyond helping those individual health centers implement and improve. But in terms of exchange of information, the health center controlled networks versus a local HIE, I'm just confused about the ultimate goal in terms of patient-based information exchange.
Yeah, well, with health center controlled networks, they originally started or formed around group purchasing. I don't believe they started around focusing on health information technology. But as the funding from HRSA evolved, they started funding networks specifically for HIT. And so many of them that are out there are specialized in a particular vendor's product, and they have a network of members who are comprised of federally qualified health centers. Not all networks are created equal. There's some that are more sophisticated than others that are out there, but there's a number that are doing health information exchange and supporting that within the community. When you talk about health information exchange, a lot of it is so state-based and regionalized and localized that health centers health center controlled networks may have a role in that or have a hand in that, but that the primary point of contact may exist outside of the network, or the organization. A lot of times that is being done either at a state level or a local level. I think a state in Virginia has maybe 2 HIEs, I think, or 2 different organizations that are coordinating that. But the purpose of health center controlled networks is really to take a group of health centers and centralize services to leverage economies of scale. I think that was the whole premise between networks, is that, why should all of these individual health centers be essentially doing the same thing and yet not coordinating efforts? And the idea was, if we just took what health centers, some core functions that all health centers need, and centralize them in a central body, and give them staff to run, that we would all be better for it, and we could do it in a more cost-effective way. And so the networks differ in their capacities of what they do. I was mentioning a lot of them have vendor-specific expertise and vendor-specific resources that they offer health centers. Some will host your EHR for you, some won't. Some will provide support, training, implementation. Some will do data aggregation and analytics, so taking data from your EHR, your practice management systems, your finance accounting systems, and putting it all in a data warehouse and running reports. Some will also help with health information exchange. It just really depends. We worked with HRSA a couple years ago to create a health network guide, or health center network guide, that is available on both HRSA's website as well as ours. So if you're interested, or for folks in the audience that are interested, if you're not part of a network, interested in joining one, there is a comprehensive listing of networks that are out there. We're working to update the list because it is a little outdated, but it's what's out there is the most recent thing that you can find. I hope that answers your question. But it just really depends on the network and what's happening in the state, regional, and local levels around health information exchange.
Do we have another question? Okay, up here in the front. Devin's coming your way.
Thank you. My name is Ginny Davidov. I'm from Resources for Human Development, and we have a health center that's part of our organization. Part of our health center has behavioral health in a variety of ways, integrated, outpatient, et cetera. How is this behavioral health included in the work that you're doing? And do you have any comments about that?
Paula,
I
go
can say
ahead.
from a practical standpoint, we have behavioral health as well at several of our sites, and we do an integrated model of care, which we also transitioned to right before we did ATHR. We really hurt ourselves by a lot of things. We did that. We did PCMH level 3 at one of the sites. It was just, what are we doing? But we ended up putting them in our chart. We did not buy a separate behavioral health HEHR. We just really learned how do we lock the notes, educate the provider, and keep it together. But since we went to the integrated model, it really made sense to help keep that information together. It's not perfect. They still have a lot of stuff they probably keep in paper and locked files in their offices, but at least it helps it helps the integration work better, that they can see, the providers can share information and make it work better. So overall, they're fairly happy. Certainly our behavioral health providers would have preferred to have something that really had their own testing and things like that in, but we ended up building patterns and templates that would work for them as well. We staged them in separately in our enrollment. Or implementation. We did not start them out right away. We got a few of the medical sites up and going underway, and then we rolled in behavioral health.
And then at the national level, as I'm sure many of you know, there are a lot of varying state laws governing the sharing of sensitive health data, behavioral health being one of them. And as you know, under the Meaningful Use Incentive Program, there are a number of specialists, providers, and sites that were not incentivized or considered eligible to adopt health IT. And behavioral health professionals happen to be one of those groups. And so right now we are leveraging the current regulatory framework to find a way to increase adoption of health IT and innovative technologies within the behavioral health setting. One that you all may have heard of is the voluntary certification program that we're working on currently with behavioral health and long-term post-acute care facilities. And the goal there is to work with vendors to create a voluntary certification program that will allow them to participate in some of the meaningful use objectives and hopefully support a more interoperable ecosystem with behavioral health data in there. And then on top of that, we're working very closely with SAMHSA, and they have a number of grants and programs available that are looking at behavioral health and mental health and exploring the privacy and security regulations at the national and state level to think about strategically on how we incorporate those facilities into the continuum of care and care transitions for our patient population.
Great. Do we have another question on the floor?
Thank you.
And while Devin is going to our next question, I just want to mention something. You know, the integration of behavioral health and other specialists into the EHR platforms is definitely something you want to be aware of when you're looking at vendors, if you're thinking of transitioning. But we talked a lot about kind of the barriers and the tough stuff related to EHR, but I mean, there's definitely, there are benefits. And one of the things that we've seen when we've gone and we've talked to people about how they're using their system, things like having your MA or your LPN do that brief depression screening. You know, that's something that can be captured in your EHR. It can be a standing order. It can be done when they're rooming the patient. And you can get a much better idea of, are we adequately screening our entire population? And the EHR really does support that and allow you to see that. Whereas before, it may have been a personal choice. There's selection bias in there in terms of, the biases of your providers and all of us. So that's a great, there are the benefits to these programs that if we use them right and if we take advantage of the systems, they really can support, better care. Next, sorry.
I would say I would have to agree with that a lot, and I think it takes several, that's one of the understandings that we learned. It takes several years to really understand what it is, to feel comfortable with your system, to know it's really working and doing what you want. But workforce analysis is really one of the next big steps, or should have been done with us when we did that, because we do have our MAs and things doing the PQ9 right at the beginning to identify that and go through that. But utilizing those staff, and now one of the things we're going back to the providers, because we're about at 80% productivity of where we were before. We have some people who have gotten back to regular and some people are still struggling. But one of the things that we're going back to the staff is saying, to the provider staff, is saying, what can your support staff do to help you see patients faster? Is there anything they can do? And it's doing those steps like that, of having everybody working up to their license and understanding what that means, and seeing, You know, we at Community Health Center, I mean, at least our Community Health Center is known that pretty much as long as you're there till you retire or till you leave. But most people know we're not going to get rid of people who are underperformers. We work around people. We're nonprofit. We're compassionate. And that's kind of got to change because it's a business. You can't have the provider working around a nurse that can't keep up anymore. And so part of it is, part of it is going back and seeing what can your staff do to help and finding places for those people or other ways that they can be helpful with the skill set they have, because it may be a nurse that has 30 years of experience, but she's just not really quick on the computer. But so how can we use that knowledge asset that she has to make that? And that's one of the people we're using for care coordinator. She knows the patients because she's been there for years, so she can call out to the patient. She knows what to look at in the data, but she wasn't quick enough to help keep the provider on a 15-appointment schedule, 15-minute appointment.
I want to be mindful of our time. So I think we've reached the top of the hour. So if you do have additional questions, especially now, you've got access to these great resources. If you have a personal question, we want to get into the nitty-gritty of it, pull one of our speakers aside and pick their brains. And also make sure you're talking to your colleagues here about the systems you're thinking about. There's got to be somebody here who's on the same platform. They may be using it differently. They might be having more success with it. So that's something Paula mentioned. You definitely want to learn for your peers on this. So once more, I just want to give a round of applause to our speakers and thank them for coming out this morning. And enjoy the rest of the day.